Thank you very much. And thank you very much to everyone who's joined us already. We've got almost 200 people online, and it's exactly 18 hours on a Thursday. So it means only one thing. It's the beginning of our weekly webinar, Clinix weekly webinars that we've been holding and hosting for the last, 4 to 5 years now. And I think we are proud that we are able to give these webinars free of charge to our healthcare professionals throughout the country and beyond. By the way, we get attendees from outside, beyond our borders as well. And we are proud that we are able to do so, but it's at the grace of Clinix Health Group. I think we are grateful to the board and to the executive committee of Clinix Health Group, the executive of Clinix Health Group, for continuing to sponsor these webinars and to an extent that we can make them free of charge to yourselves. Over and above, of course, we do have HPCSA accreditation for our webinars. So both the presenters and the all attendees who registered, and I'll attend to that just now, who have registered themselves to receive a Zoom platform will be, the status with HPCSA will be updated within 2 to 3 weeks with accreditation of your crediting of your profile with HPCSA, with CPD points from this webinar. I think that's provided when you registered yourself. You didn't get the Zoom link secondhand, in a way. So you registered yourself to receive the Zoom link, because when you register, you have to put in your HPCSA number, not your MPA, your practice number, like some people still continue to do, unfortunately. And then they come to us they don't get the CPD points. You have to use the body that you are registered with. If it's HPCSA, you give your registration number, not your practice number or any other number. If it's Nursing Council, South African Nursing Council, use that number. If it's Pharmacy Council, the same. So that's what you do. If you got the Zoom link second hand or third hand, of course, you'll be able to join, but you are welcome to join us, but you will not then be credited with CPD points. We're also grateful for all our specialists, our experts in our healthcare, who continue to give of their time and their expertise to share their time and expertise with us, with all their colleagues throughout the country, almost free of charge, actually free of charge, and out of the love of knowledge sharing. And I think we are grateful to all the people who continue week after week for so many years to give of their time and share their knowledge with us. We're very grateful. I will soon introduce the speaker of today. You can see on the screen. But before I do that, I will, just to let you know that we will mute you, so you won't be able to ask questions or talk until after he has finished his presentation. Thereafter, we will be allowed to raise your electronic hands, and then you can put your questions or your comments orally if you like to do that. But you'll also, during his presentation, be able to type your question or comments, even during the presentation, on the chat box. So please put your comments on the chat box, and the speaker will attend to them after, during the Q&A session. Our speaker today is Dr. Nkosikhona Mlimi. Dr. Mlimi is a general surgeon, but he's also a specialist metabolic and bariatric surgeon as well. Something that is not, you don't get it everywhere. It's I think he's one of the rare super specialists. I don't call them subspecialists. I call them super specialists because they've done more than all of us. And I think for that we are grateful. He qualified in laparoscopic and bariatric surgery. His initial MBCHB degree is from Medunsa. He's got a FCS, South Africa, with the Colleges of Medicine of South Africa, and he's also got his MEd from SMU, Sefako Medical University of South Africa. Sefako University of of Health Sciences, just to correct myself. Dr. Mlimi is trained and serves as a specialist consultant in minimally visceral and metabolic bariatric surgery at Dr. George Mukhari Hospital, gaining extensive experience in advanced laparoscopic surgery, including bariatric procedures, anti-reflux surgery, minimally invasive esophageal and gastric surgery, and also complex hernia repairs. He currently practices also at Clinix, Dr. S.K. Matseke Memorial Hospital, where he co-leads a partnership with Dr. Winnie Mate, who's also his colleague and bariatric surgeon herself. They call their practice Premium Weight Management Experience, which they have registered and patented. Premium Weight Management Experience, a multidisciplinary program focused on evidence-based long-term weight management. His approach combines surgical expertise with personalized, compassionate care to support patients throughout their weight loss journey, because it's not an event, it's a journey. Now, as I've said, Dr. Mlimi, before I hand over to you, maybe as I hand over to you, please inform your colleagues, because it's not all of us who know what the South African what do you call the South African Society? South African Metabolic Medicine and Surgery Society, SAMS. South African Metabolic Medicine and Surgery Society is what is this body, what it means to be accredited by them, before as I hand over to you. But over to you, Doc. Thank you very much.
Thank you. Thanks, Dr. Kinoshi, for that kind introduction. And good evening to everybody in attendance. A very special greeting to my mentor and without doubt, the best surgical educator in the country, Professor MZ Koto, without whose guidance and knowledge we probably wouldn't be where we are today. Really is a great man. I think we must give him his flowers while he can still smell them. As you've said, Dr. Kinoshi, our hospital, that being Dr. S.K. Matseke Memorial Hospital, recently received accreditation from the South African Metabolic Medicine and Surgery Society, which is quite a mouthful. For the sake of simplicity, we can just call it SAMS. So what is it? What it is, it's a body that aims to sort of coordinate the management of obesity in South Africa. Of course, there's a heavy leaning towards surgery or metabolic surgery or bariatric surgery, but really it's a society that's open to anybody who has an interest in the management of obesity, anybody who has an interest in what's going on in the world of obesity, who has an interest in what's happening in metabolic surgery. So it's open to everybody, dietitians, physiotherapists, physicians, subspecialist physicians, surgeons, even general practitioners and the like. And the idea is that the more people we can have, leading the conversation on obesity, then the higher the impact we can have on this pandemic. So that's what SAMS is. And you mentioned that we recently got accreditation to perform metabolic bariatric surgery. What that means is then we've undergone the requisite training as members of the team. I'll show you a picture of our team there right at the end of the presentation. As members of the team, we've undergone the requisite training. The society, being SAMS, has come through to our facility. They've done an inspection and they're of the opinion that it is a facility that is at the right standard to manage patients who are undergoing metabolic or bariatric surgery. And that's what the accreditation means. So it means when you send patients to us, when patients come to us in this hospital, they're going to be looked after by a team that is quite knowledgeable, and they're going to be in a facility that is equipped or geared towards having the best outcomes when the patients come for bariatric surgery. So that's what accreditation means in a nutshell. It's a very very tedious thing that we went through. I think you yourself know where we started, Dr. Kinoshi, and the difficulties that we encountered. But earlier this year, they came through, they did the facility inspection, they went into the theater and they watched the two surgeons operate. They had a discussion with the members of the team, and they were happy, and they issued us the certificate. And since then, really the team has hit the ground running. We've had some challenges here and there with uploading our data onto the database, but I think we can safely say we've done probably close to around 50 patients or so ever since we got accreditation, which is no mean feat. So that's where we are as the the metabolic medicine unit at Dr. S.K. Matseke Memorial Hospital. So my talk today will be very brief, maybe a little bit boring for those who are not surgically inclined, but I think there's something for all of us to take away, seeing as we are in the midst of a very, very serious pandemic, that being obesity. All right, so where I want to start is, with this definition of what obesity is that came out in 2022 from the Obesity Medicine Association. And I think there's one that comes from the the SA Obesity Guideline, which came out last year, which sort of captures what this definition says. So what they say here is that obesity is a chronic, progressive, relapsing, treatable disease. So when we think about how we're going to manage obesity, we must look at it in that frame to say this is something which is chronic. So we're never going to cure the patients. All we want to do is to give them a tool to help them manage the disease. It is progressive in nature. In other words, it gets worse if nothing is done. And I think anyone who practices clinical medicine sees the effects of untreated obesity. It is relapsing in nature. So the treatment must be that of a chronic disease in that you're going to manage this lifelong. However, it is treatable. It's a complex disease. It's multifactorial, mainly based on neurology, gut physiology, and a little bit of behavioral science or psychology. And it's characterized by an increase in body fat, which then results in adipose tissue dysfunction, which then gives you all those complications that I've mentioned there, physical forces, metabolic, biochemical, and psychosocial health consequences. And so when you think about the outcomes that you are treating, it must be in that line to say the solution that I'm offering this patient, what does it do to the metabolic complications that they've now developed from the obesity? The solution that I'm offering this patient, what does it do to the biomechanical? What does it do to the psychosocial health consequences? So I think it's a very nice definition because it covers really what the problem is with obesity and what you really should be aiming for when you suggest a management modality for the patients. I think this is something which is familiar to everybody. This is the concept of a body mass index. It's a fairly straightforward calculation where you divide the patient's weight in kilograms by their height in meters times their height in meters. So it gives you a number in kilograms per meter square that then allows you to stratify or categorize the patient. And I think the numbers that we are really worried about are the numbers from this here line, anything above 25. So between 25 to 25.9, that is the overweight range, and anything above 30 is the obese range, in which there is class 1, class 2, and class 3. I know there are some sources that talk about class 4 and class 5 obesity, but that's not really in the mainstream as yet. So there are some problems with the body mass index in the sense that, the cutoffs are very different for certain populations. So in an Asian population, anything above 27.5 is actually obese. The second problem with the BMI is that it doesn't distinguish fat, which is what you're worried about, from muscle mass. And the third problem, I think, which is also important, is that it doesn't really say anything about where this fat is, because we have an understanding that visceral fat or truncal obesity has worse metabolic and health outcomes than, say, adiposity around the thigh. So those are some of the problems with the BMI. But at a population level, I think this is what works. And if we look at the guidelines, they still talk about a body mass index or the certain cutoffs of body mass index when you talk about offering patients something like metabolic bariatric surgery. So this is something we haven't written it off as yet, although we are aware of the problems that come with the BMI. Then to try and work around that, the Lancet Commission on Obesity released this report last year that talks about the definition and the diagnostic criteria for clinical obesity. And what they really said here is that there's really two types of obesity. There's something called preclinical obesity, where the person has got an increased BMI, i.e. anything above 30, and there's some other anthropometric measurement, like the waist circumference, which is above normal, which then results in these problems, but in the absence of any clinical manifestation. So that would be how they define preclinical obesity. Using the same parameters, a BMI above 30 and some other anthropometric measurement like the waist circumference or the waist to height ratio or the abdominal circumference, or actually measuring the percentage of fat using a special machine like an impedance. In the presence of altered organ function or end organ damage, that is now the definition of clinical obesity. And I think the key thing here is to say we haven't thrown out the BMI. We have, however, added other anthropometric measurements to supplement the BMI. As I mentioned, the waist circumference, the waist to height ratio, the waist to hip ratio, the total body fat percentage. What is important though is that in the same document where they say, look, it's a BMI plus some other anthropometric measurement, they say you can safely presume that an individual with a BMI above 40 has got excess adiposity, right? Because that really is the thing that drives the problems that come with obesity. It's the excess adiposity. So yes, we recognize the shortcomings of the BMI. Yes, we are saying we're adding other anthropometric measurements to supplement the BMI. But in an individual with a BMI above 40, it's safe to assume that this person has got excess adiposity. So how big is this problem? I think this is not new information to most of us who practice any sort of clinical medicine, in the sense that somewhere between 20 to 40% of all South African women are either overweight or obese, and somewhere between 12 to 15% of South African men are either overweight or obese. Here, I didn't put a diagram, but there's another looming pandemic that we're going to face in the future, and that is the problem of obesity in adolescents or in the pediatric population. What is important to note here is that these numbers are on an upward trend, number one. And what you're seeing is there's actually a much faster increase in the higher BMI patients than in just the general population. So the problem of obesity is one that's, if it hasn't already overwhelmed the healthcare system, it's one that's going to do that in the future. And so we need to think about what we're going to do about it as people who are in the front line who are seeing this problem head on. So when you think about obesity at the societal level, we say this thing is fairly straightforward, right? In a person who expands as many calories as they take in, that person's weight will be stable, right? In an individual who takes in excess calories and they don't burn all those calories off, then they gain weight. And in somebody who's got the reverse of that, then they will lose weight. So the thinking is it's a fairly straightforward thing. You must eat less and exercise more. However, because of the increasing trends globally in obesity, we've come to realize that this simple equation is not so simple. Then we moved to something else. We said, oh, okay, there's still some sort of energy imbalance here, but this is something which is environmental in nature in the background of genetics. So there's an influence on behavior and human physiology, all these middle steps. And at the end, you come out with the same energy balance and storage. And so you try and tinker with some of these things, you should get somewhere with this person's weight. We tried this one as well, and the numbers just kept going in the same direction. And then people did a little bit more research and they said, well, this thing is maybe a little bit more complex than we thought. Okay. this thing is a little bit more complex than we thought. And so this is now our current understanding of the pathophysiology of obesity. What we're saying is this is a very complex interaction between the brain, the gastrointestinal tract, and the adipose tissue itself, where these three systems are in constant communication to regulate your appetite and your weight. All of this, of course, happens in the background of some genetic influence in the sense that people who are living with obesity, somewhere between 40 and 70%, are coming from so-called big families. But this is our best and current understanding of the problem of obesity, or how it comes to be, in the sense that these three systems are in constant communication with each other. And the way that they do that are via the neurohormones, right? In this diagrams, the letters in bold. Some of them will be familiar to everybody, like GLP-1. Some of them will not be so familiar, like neuropeptide Y and cholecystokinin and all of that. But in essence, in individuals who are living with obesity, the signaling amongst these three systems is deranged. Either the messages are not being sent properly, or they're not being received properly, or they're not being acted upon properly, such that there is then excess adiposity. And this adipose tissue, we tend to think of it as just a storage area that, is just holding adipose tissue, it's holding calories so you can release them. However, we've come to understand that adipose tissue is a little bit more complex than that. It's a functional, a functional system. It secretes interleukins, it secretes pro-inflammatory cytokines that sort of then drive and maintain the obesity. And so if you want to make any meaningful impact in somebody's weight, you must deal with the levels of these neurohormones. And I think from the obesity management medications, which are everywhere now, we have seen that really the two big ones are GIP and GLP-1. Of course, there's now a triple agonist, which is in phase 3 trials, which also deals with the levels of glucagon. But in essence, if you want to manage somebody's weight, and if you want to do it in a significant and sustained way, you must somehow change the levels of these neurohormones. Otherwise, the solution that you're proposing won't work, or it won't work very well. That's why, or that's how you can then understand that diet and exercise on their own do nothing to these neurohormonal levels. That's why diet and exercise don't really make any meaningful impact insofar as long-term weight management is concerned, right? Then you think about something like the obesity management medications. They alter the levels of GLP-1, GIP, and glucagon in this new one that's coming out probably sometime soon. And in so doing, they change how the brain, how the gastrointestinal tract communicates with the brain, communicates with the adipose tissue, etc., etc. And if you put metabolic or bariatric surgery in the right context, what it does is it changes the levels of these neurohormones in a significant and sustained way. And that's why when we're talking about long-term outcomes, nothing comes close to metabolic or bariatric surgery. Then the Lancet Commission took it one step further. Sorry, I hope this is not in the way. Let's put it there. They took it one step further and they say, look, this is how things happen. There is, for some unknown reasons, an increase in adipose tissue. This then results in alterations in the homeostasis of the fat mass. It results in changes in your appetite and your satiety. Then you have excess adiposity, which is the hallmark of obesity. Then the adipose tissue itself then becomes pathological in the sense that it releases adipokines, etc., which then results in all these systemic problems, which gives you then organ dysfunction and at the end, clinical obesity. And so what you want to do is you want to break the chain somewhere up there where you have alterations in your homeostatic regulation of the adipose tissue, the problems of appetite and satiety, and that's where changing these neurohormonal levels really comes in. All right. I think this is probably something that's not new to anybody who practices clinical medicine, in the sense that really there is no body system that is not negatively affected by obesity. In a sense, obesity is the gift that keeps on giving, or in this case, it's the gift that keeps on taking away. So all body systems, right from the head down to the toe, is negatively affected by obesity, right? You can name any disease or any pathological process, obesity will have an adverse effect on that disease, right? From mental health care issues in the chest, in the gastrointestinal tract. This is dermatological. This is endocrine, etc., etc. But I think really the three big issues that need us to act and to act quickly are these ones. The first is the increased risk of malignancy, right? So obesity itself is associated with about 13 different types of cancers. That's problem number one. Problem number two, individuals who are living with obesity have got a poorer quality of life. And when you talk about the resolution of comorbidities from whichever intervention or solution that you're going to offer a patient, you get varying numbers. There's a certain amount of remission of diabetes, there's a certain amount of remission of dyslipidemia, hypertension, etc., etc. But almost universally, what you will find in individuals who have undergone metabolic bariatric surgery is that their quality of life is much better, even in the absence of the remission or resolution of the obesity-related comorbidities. And I think this one is also quite important. What has been shown is that individuals who are offered metabolic bariatric surgery, on average, you add somewhere between 5 to 12 years to somebody's life. So yes, all these problems abound with obesity. And if we look at some of the problems that come with obesity, then we must say to ourselves, there's no clinician who has not seen an obese patient. There's no clinician who has not struggled or who has not had challenges, to put it like that, with somebody who's living with obesity and some other problem that I've mentioned here. But really, the big three here in the middle are the ones that need us to act and to act quickly. So what must be done about this thing? I think where we must start is here to say what we're dealing with here is actually a disease. This is not a failure of willpower. This is not lazy people. Here, what we're dealing with is a chronic disease. So we must recognize obesity as a disease in the sense that if you see a patient who has come in with an ankle fracture, lateral malleolar fracture, fine, that's the one problem, but this person has also got a BMI over 43. And so when you make clinical notes, you must say to yourself, I'm going to sort out the problem that this individual came in with, but there's also this one. What am I doing about it? Who am I talking to so that we can help this person manage this other problem of obesity as well? And so when we think about the management of this disease, there's really about 4 different steps. That is lifestyle intervention, pharmacotherapy, the endoscopic devices, and metabolic bariatric surgery. I won't go too much into lifestyle modification and pharmacotherapy. I'll stick mainly towards endoscopic devices and metabolic and bariatric surgery. So the way we tend to think of it is to say, look, the higher the person's BMI, then we should escalate, the treatment. So, well, let's start with a little bit of diet and exercise. And if that doesn't work, then maybe we should go to something like pharmacotherapy. And if that doesn't work, then we should think about something endoscopic. And if that has failed, maybe we should consider metabolic bariatric surgery. And I think that's maybe not the right way to approach the problem. Insofar as diet and exercise are concerned, they are the foundation of the management of obesity. Regardless of whichever one you decide to go with up here, there is benefit from everybody having, I think, said 150 minutes of increased physical activity every month, eating the right diet, etc., etc. So diet and exercise, yes, they are the foundation of obesity management. Then we come to the pharmacotherapy or the obesity management medications, which are the talk of the town. And the way I've written them here is, patients would start on the drug. They maybe wouldn't get a good physiological response, or they can't tolerate the side effects, or they have inadequate weight loss. Then they stop. Then they come and try something else, something from a different class, go maybe with a dual agonist rather than a single agonist. Use that, not get where they want to go, stop, maybe try something else. There is a role for pharmacotherapy, also in the context of metabolic surgery. I think I'll touch on that a little bit. Then, of course, there are now the endoscopic devices like intragastric balloons and endoscopic sleeve gastroplasty. I don't really want to say much about intragastric balloons, mainly because this, in my opinion, is a temporary solution because all balloons must come out at some point in time. I think there's one on the market which can be left intragastric for about a year, but all the others must come out at 6 months. And there is 100% weight regain when the people, take out the balloons, and the metabolic effect is very minimal. So I don't advocate for balloons much. Then, of course, right at the top, we have metabolic and bariatric surgery. And I think the question that we must ask when we have the conversation with patients about how we are going to manage the weight, we must say to ourselves, how far will this modality take my patient? Right? What is it that I want to achieve when I'm managing this obesity? Am I chasing purely weight loss? Do I want the resolution or the remission of some of the obesity or some of the obesity-related comorbidities? And then you choose the right treatment modality on the scale here. Of course, diet and exercise or lifestyle modification should be the foundation of whichever one you decide to go with. And in thinking about which solution you're going to go with the patient, I think this is really an excellent chart that looks at, the total body weight loss over time, comparing four different modalities. Here in the gray is lifestyle. Then you have one of those GLP-1 receptor agonists, something like semaglutide. Then you have a sleeve gastrectomy, and you have the gold standard in long-term weight management, that being the Roux-en-Y gastric bypass. What we see there is that at 2 years, yes, the patients who are using some of these obesity management medications will have lost a significant amount of weight, probably somewhere between 8, 10, maybe 12%, depending on which agent they're using. But they regain almost all that weight. This is, of course, now the people who have managed to stay on the drugs, because quite a lot, somewhere between 50 to 60% of the people who start these drugs actually stop taking them at 2 years. And critically, lifestyle only, that being diet and exercise, doesn't really result in significant or sustained weight loss. The best that you're going to get is probably somewhere around 5, 7%. And that's now in somebody who sticks very strictly to the program diet or the exercise program, somebody who sticks very strictly to the dietary advice and to the dietary program that the dietitians will prescribe for them. Then, of course, the gold standard down here, that is the Roux-en-Y gastric bypass. So when you think about, having a conversation about somebody who's living with obesity, this must be what is at the back of your mind to say, how long do I want to manage this obesity? And if we go back to the first slide, the second slide there, we said this is a chronic disease. So this is just 10 years. You'll be managing this disease for 20, 30 years in a very young individual. How far will your management modality take this patient? All right. Then no discussion on metabolic or bariatric medicine will be complete without the obesity management medications. They are really the talk of the town. Everybody and their grandmother is on Ozempic. And these drugs work. They work very well. I've never had a patient who said to me, I don't want the surgery. I'm going to try one of these drugs. And I've said no. The drugs work. They work very well. They work very well in the people in whom they do work because they have got their own problems. They are biological non-responders to obesity management medications. There are people who just can't tolerate the side effects, especially gastrointestinal. There are people who are really, concerned about the acute pancreatitis and this increased risk of thyroid cancer that comes with the drugs. So when it comes to obesity management medications, they do work, but if you decide that you're going to go with this management modality, then the question is, which patient am I going to give which drug? For how long am I going to give this drug? At what cost and to what endpoint? What is it exactly that I want to get out of the management of this obesity? Do I want just purely weight loss? Do I want some metabolic benefit? Do I want the highest chance of the resolution of some of these obesity-related comorbidities like diabetes and hypertension? And if the answer is, something more towards more metabolic than just purely weight, then the obesity management medications are really not the best that you can offer the patient. But the drugs work and they work very well. I think here we have tirzepatide, which is Mounjaro. That's the one, probably the strongest one that we have in the country. There is retatrutide now, which is in phase 3 trials, and it's showing numbers of weight loss that that are threatening what you get with a sleeve gastrectomy. So the drugs work; they work very well. Of course, you must then ask yourself those different questions. What is the mortality benefit of this medication? And if I'm talking about, the resolution of the comorbidities, how does this drug compare to something which is the gold standard, like a Roux and white gastric bypass? And of course, no talk on obesity or metabolic medicine will be complete without a quote on the SOS trial. And this is really the seminal paper that has demonstrated the long-term durability of metabolic bariatric surgery. The numbers there are just amazing. The numbers are really just amazing. I'm not sure if you can see the last sentence on the slide there, and it says that, this benefit was maintained up to 20-year follow-up. This was sustained at up to a 20-year follow-up, right? So if you're looking for something which is durable, if you're looking for something which is really, really effective, I mean, a 78% type 2 diabetes remission at 2 years, then really nothing comes close to metabolic and bariatric surgery, right? And some of the procedures that we are doing now, which I will go into a little bit later in the slide, they've got better numbers than what was found in this SOS trial. But really, this is the seminal paper. And if you remember one slide from this presentation, okay, if you remember two slides, it will be this one and that one with the graph about long-term weight loss. Okay, so what are the indications for metabolic and bariatric surgery? I think one thing that may be a little bit confusing, it's metabolic and bariatric surgery. It's metabolic dash bariatric surgery. It's metabolic slash bariatric surgery. So in the past, metabolic surgery was a procedure that you offered somebody to help them manage some of the metabolic complications that come with obesity. So it's an operation that you'd offer to somebody who's obese and has type 2 diabetes, who's obese and got dyslipidemia, who's obese and is living with the obstructive sleep apnea. That's what metabolic medicine was. And bariatric surgery was an operation that you offered somebody purely with the intention of helping them lose weight. I think that distinction has become a little bit, arbitrary, in the sense that a lot of people who are living with obesity have got some metabolic dysfunction, whether they are or not aware of it. So it has now become just metabolic bariatric surgery. No and, no hash, no dash, no slash. So it's metabolic bariatric surgery because for almost all the individuals who are living with this disease, there is a metabolic benefit. So in 2022, the American Society for Metabolic and Bariatric Surgery, as well as IFSO, which is the International Federation for the Surgery of Obesity and Metabolic Disorders, came out with an update on their 1991 guideline on who should be offered metabolic bariatric surgery. And the real big thing that they came out with here was to say we're going to lower the threshold, right? In the 1991 guideline, it said, you should recommend metabolic bariatric surgery for individuals with a BMI above 40. In 2022, they lowered the threshold and they said we can come down to anything above 35 kilograms per meter squared in the absence, the presence, or the severity of any comorbidity. Then the second indication they said was metabolic bariatric surgery is recommended in patients with type 2 diabetes and a BMI above 30. And I think there's lots of evidence, lots of data that suggests that, individuals who are living with type 2 diabetes who are offered metabolic bariatric surgery, especially at the BMI above 30, tend to have much, much better outcomes than individuals who just have type 2 diabetes who are given medical management in the presence of obesity. Then they said you should consider metabolic bariatric surgery in individuals with a BMI between 30 and 34.9 who do not achieve sustainable or durable weight loss using non-surgical methods. Now, in an ideal world, this would be fairly straightforward, but it does give a few problems when you try and speak to the funders about offering somebody with a BMI of 33, for example, metabolic bariatric surgery, because quite a lot of the funders are still holding on to the old 1991 guideline, in spite of the fact that SAMS keeps on engaging them and updating them with this guideline that came out in 2022. So this is something then to throw into the conversation whenever you see somebody who's living with obesity, to say, there is that provision in the guideline to say that, if you've tried other non-surgical methods, there's a role for metabolic bariatric surgery, even though strictly speaking, you are below that threshold of 35 kilograms per meter squared. Right? And then there's no upper age limit for metabolic and bariatric surgery. Of course, weighing the risk and the benefit. Then, as I said at the beginning of the presentation, this is another one that we're going to see as time goes by. Children and adolescent obesity is going to become a big problem. So there is a role, according to the ASMBS and IFSO, for metabolic bariatric surgery in adolescents and children. I think it's a little bit of a niche area, but it's also a discussion to have, with parents and other people who look after children and adolescents, to say there is a solution that is significant and sustained in the form of metabolic bariatric surgery, but it's a little bit more involved than bariatric or metabolic surgery in an adult. And critically, you may consider metabolic bariatric surgery as a bridge to some other treatment, something like a joint arthroplasty, an abdominal wall hernia repair, or organ transplantation. And I think the individuals who do joint arthroplasty, they can attest to the fact that if you do arthroplasty in an individual with a normal, in inverted commas, BMI, compared to somebody who's up there above 35, the outcomes are very different. The individuals who do abdominal wall hernia repair, we know very well that if you repair a hernia in an individual with a BMI of 45, that really is a waste of that person's time. And it has been shown that the grafts tend to have better survival in individuals who are of normal weight or in the healthy BMI range compared to overweight individuals. So really, that is what the ASMBS and IFSO said in 2022, and this should be the guiding document. It's also replicated in the SA obesity guideline, which came out late last year. So where are we in 2026? These are the four main procedures which are being performed worldwide. On the left-hand side is the sleeve and the Roux-en-Y gastric bypass. These are by far the leaders. And the so-called new kids on the block, the one anastomosis gastric bypass and the SADI S. What the SADI S is a single anastomosis duodenal bypass with a sleeve gastrectomy. Worldwide, most procedures are of the sleeve gastrectomy variety, followed by the Roux-en-Y. That's why they are the two biggest picture there. And then round about maybe 3% of all procedures around the world are mini gastric bypasses, also called the one anastomosis gastric bypass, and the SADI is sort of up and coming. So I'll go into a little bit of detail into these three into the three different procedures. Right. So for the longest time, the Roux-en-Y gastric bypass was the so-called gold standard. So whenever somebody came up with a new operation to help people manage their weight, we'd always compare the outcomes to the Roux-en-Y gastric bypass, mainly based on the fact that it has got, the longest data outcomes. We know what happens with Roux-en-Y gastric bypass patients 25, 30 years after they've had their procedure. They tend to do much better than the sleeve patients. And so for the longest time, the Roux-en-Y gastric bypass was the gold standard. And to a certain extent, it still should be considered that. But there are some real challenges insofar as the mini and the SADI are concerned. So where are we in... Sorry, can I just close this? So where are we in 2026? The sleeve, by far, still leading, probably between 50 to 60% of all metabolic procedures globally are sleeves. The one anastomosis gastric bypass is now up and coming. This is now third to the Roux-en-Y gastric bypass. The SADI-S is also the fastest growing in the severely obese individuals. That's now the BMIs above 50, which is where the SADI works really, really well, and as a revisional procedure. And of course, something that we need to think about is the age of robotics, in the sense that, round about 1/3 of all bariatric procedures in 2022 in the US were performed via robotics. Then, of course, we can't rule out the GLP-1s. They will always be there in the conversation. Yes, we are seeing a shift in the referral patterns, but the GLP-1s won't replace surgery. I think the role that they are playing really is to be a conversation starter, and we can then point people living with obesity in the right direction to say, look, at a BMI above 50, sorry, with a couple of obesity-related comorbidities, you're unlikely to achieve significant or sustained weight loss with just one of these drugs. Maybe you should think about surgery. So the one anastomosis gastric bypass versus the Roux-en-Y gastric bypass. So this is now the third most commonly performed procedure worldwide. I think it's somewhere around 5, maybe 10%. Fairly straightforward. You fashion a small pouch from the stomach. Then you have one anastomosis, unlike the two anastomoses from the Roux-en-Y gastric bypass. So it's a simple operation, tends to be faster, it's very easy to learn, and it's easy to reproduce because there's no variability, in how long you're going to make this limb and make that other limb, etc., etc. And in some randomized controlled trials, it's actually showing superior weight loss compared to the gold standard, that being the Roux-en-Y gastric bypass. It has got its own problems in the sense that you now have this very small pouch being exposed to quite a lot of bile reflux. There's, of course, the risk of marginal ulcers there where you've made the anastomosis. And in theory, because now you expose this stomach, or this pouch has got a chronic exposure to bile, theoretically, that then becomes a nidus of chronic inflammation, which is the first step, or chronic gastritis, sorry, which is the first step in the development of gastric adenocarcinoma. But it's a really good operation. And if we look at where the one anastomosis gastric bypass shines, at 12 months, it has got significantly higher excess weight loss compared to the Roux-en-Y gastric bypass. Then, if we look at the 2-year follow-up, it has got a statistically significantly lower post-op BMI versus the gold standard. It has got a shorter operating time because you now have to make one anastomosis instead of two. You only have to count one limb or count one bowel length instead of two. It seems to be superior insofar as dyslipidemia is concerned, and it seems to have fewer early complications compared to the gold standard. As mentioned before, there are all those problems that in theory, you are exposing the stomach to bile in a chronic sort of setting, which then sets off chronic gastritis and down that whole cascade to gastric adenocarcinoma. The other issues, of course, is that this is a complex operation when you need to revise it. So if you have somebody who's then got unbearable bile reflux or who has developed marginal ulcers that are not responding to any intervention, it may be a little bit of a challenge. But really, it's starting to challenge the Roux-en-Y gastric bypass. And when I have consultations with patients, I explain to them that, look, the Roux-en-Y gastric bypass is the gold standard. However, there's this other thing, which is the one anastomosis gastric bypass. It's something that you should look into as well. Okay. So who's the ideal patient for a mini gastric bypass, right? This is somebody who ideally does not have any gastroesophageal reflux disease, somebody on the higher BMI side. It works extremely well in the patients who have got type 2 diabetes. It works fairly okay as a revisional procedure, right? And it's something that we maybe should avoid in patients who have got pre-existing gastroesophageal reflux disease or hiatal hernia or esophagitis, in the individuals who have got a history of peptic ulcer disease. And it's really not the ideal one for the patients who have got symptoms or who are worried about, post-operative reflux. So this is something that I say when I talk to the patients. I say, look, the risk of symptomatic bowel reflux is very low, somewhere around 4% or so, but it's a very real risk. And for most of the individuals who already have got gastroesophageal reflux or reflux symptoms, then they tend to err on the side of caution and not choose the one anastomosis gastric bypass. Then we have the SADI, which is the single anastomosis duodenal bypass with a sleeve. So what you do in this procedure is you have a sleeve gastrectomy, and then you calculate the length of the small bowel from the ileocecal valve, and you make a common channel of around 300 centimeters. So from your duodenal anastomosis to the ileocecal valve is about 300 centimeters. That's the so-called common channel. And how it's then supposed to work, it's a bit like a combination of the sleeve and the mini gastric bypass in the sense that you have one anastomosis instead of two. So the SETI really is the heavy hitter when it comes to excess weight loss. In quite a lot of meta-analyses, it has actually got greater weight loss than the Roux-en-Y and the mini gastric bypass at different time points. It has got much, much superior type 2 diabetes remission, approaching that of a biliopancreatic diversion or duodenal switch, which is an operation that has now been abandoned because of the nutritional complications that come with this procedure, right? It is, or it should be, the preferred revisional option after a failed sleeve gastrectomy. Yes, there is that option of converting a sleeve to a Roux-en-Y, but I think if one follows the data, you get much better outcomes if you convert a sleeve to a SETI rather than a Roux-en-Y. It has got its own problems as well. It's a little bit technically challenging, especially in the port placement. And if you consider that the best cohort of patients who benefit from this operation are actually super obese. So that makes it also a little bit more challenging. But it's a really great operation, and I think if we can get more people who know how to do it, then really we shouldn't see that many complications from the SETI. So if we look at what the data says, looking at different time points, 12, 24, 36, and 60 months, we can see that the SADI-S has got superior weight loss to both the Roux-en-Y gastric bypass and the one anastomosis gastric bypass, right? So when you compare the SADI to the Roux-en-Y, there's significantly higher total weight loss at all the endpoints. If you compare the SADI to the one anastomosis or the mini gastric bypass, there's a higher total weight loss and higher excess weight loss at 12 and 24 months with lower bile reflux, which is the main concern with the one anastomosis gastric bypass. And looking at the 5-year data, you have about 30% total weight loss that is sustained at 5 years, and very high rates of type 2 diabetes remission. Right. Of course, it has got its own problems here, especially because the learning curve is quite steep. So in those first few cases, you may run into complications, but it's a really good operation. And I think if we can master this one, then we're going to make some really meaningful impact in the lives of people living with obesity. Right. As I said, so it delivers about 40% total weight loss. And it ideally should be, the first line treatment in the so-called super obese individuals with BMI equal to or above 50 kilograms per meter square. And it's got very high type 2 diabetes remission rates, right? And this malabsorptive component drives superior dyslipidemia outcomes compared to something which is just purely restrictive like a sleeve or something of a bypass nature like the Roux-en-Y or the Mini. It should be the operation of choice when you're talking about revisions, which is something that we're going to see more and more of because the sleeve has got quite a lot of issues in some series. Somewhere between 15 to 20% of the patients who have had a sleeve need a second operation within 15 years of the sleeve. So when we think about revising these patients, I think we should defer to a SADI rather than a Roux-en-Y gastric bypass. Of course, as I already mentioned, the learning curve is very steep here, especially if you consider the ideal patient for a SADI. It should be the super obese. Then, of course, something which is now up and coming, the ESG, which is the endoscopic sleeve gastroplasty. Sorry, I put the wrong picture there. But in essence, what you do in an endoscopic sleeve gastroplasty is you insert a gastroscope into the stomach, and then you plicate the stomach from inside. So this is something which is usually done as an outpatient setting. There's no incisions, and most of the people go home on the same day. It's usually done as a day procedure. You don't even need admission. So IFSO came out with a formal position statement in 2024, which I won't really go into now. But if you look at the total weight loss that comes with an endoscopic sleeve gastroplasty, it's somewhere between 15 to 20%, which is sustained at 5 years. Sorry. And the National Institutes for Health and Care Excellence actually endorsed the ESG in 2024 for selected patients, those being individuals with BMI between 27 and 35. So they are in the overweight or obese range, but they are not quite at the threshold for metabolic bariatric surgery. It should not really be seen as a replacement for surgery. It is its own, distinct therapeutic option for that subset of patients. Right? So if we look at how the numbers look for the ESG, we see that at 6 months, you have about 15% total body weight loss. At 24 months, stable. At 60 months, still stable around 15, 16%. So it works really, really well. It's a good procedure for the individuals who are not at that threshold of 35 kilograms per meter squared, but are obese, or for the people who are not fit for surgery, or for the individuals who do not want surgery. And then, of course, the dream, that being robotic surgery, has exploded in the US. They moved from around 7 to more than 30%, of their procedures are being performed using a robot. And there's quite a lot of data. There's this MBSA quality improvement project data, which looked at 823,000 procedures. And what they really found was that, where robotics comes in is when you're doing a revisional surgery. That's really where the robot has got the best outcomes. When you're doing something as simple, in inverted commas, as a sleeve, there really is no benefit, right, in using a robot. But this is something to think about. I'd hope the executive management of Clinix is listening, because as I said, as we move forward, we're going to do quite a lot of revisions because there's a lot of sleeves, and the sleeve is sort of an inferior operation, especially in the long term. So we're going to need to do quite a few revisions. And if we can get a robot, then really we're going to have better outcomes than just a straightforward laparoscope. Okay, so where does the robot fit in? It really fits in here, where you're doing revisional surgery. There's lower morbidity, there's lower risk of blood transfusion, wound infections, decreased length of stay, at the risk of slightly increased operating theater time when you have to dock, undock, and all of that. But the robot is really the clear winner when it comes to revisional surgery. So, what would I recommend? I'll put, a disclaimer and say that this is sort of the way that I think about choosing a procedure or making a recommendation for a patient. I accept that other practitioners, other surgeons may not necessarily agree with this, but I think it sort of gives a good outline or a good framework for when you start the conversation with somebody who's living with obesity to say, there are all these different options. There's ESG, there's Roux-en-Y, there's sleeve, etc., etc. And for you, I think this is the operation that you should go with based on your profile. So for the individual with a BMI between 27 and 35, not 40, who has got no gastroesophageal reflux disease, who doesn't want surgery, who cannot afford, long-term or permanent GLP-1 agonist, and endoscopic sleeve gastroplasty is a good sort of compromise, right? For the individual with a BMI above 35, somewhere between 35 and 45, we can say maybe 35, 40, who has got gastroesophageal reflux disease, the Roux-en-Y is really the operation to go for. The same individual who has got no gastroesophageal reflux disease, you can go for either a one anastomosis or Roux-en-Y gastric bypass. And if the patient really insists on a sleeve gastrectomy, then you can offer them that. But really, this is a poor operation, it's inferior. I do not routinely recommend sleeves, but for the people who believe that this is what will work for them, I do sleeves for them. In the individual with a BMI equal to or above 50, really a SADE is the operation that you'd want, failing which you can settle for a Roux-en-Y. It's a safer procedure, especially if you consider that it's more easily performed or more commonly performed than a SADE. Then in somebody who's got severe type 2 diabetes with the BMI above 30, as it said in that ASMBS if so guideline, that person can be offered a Roux-en-Y or a SADE. Some may argue that, a BMI of 32 is maybe not or rather a SAID is a little bit too aggressive for somebody with a low BMI like 32. But really, in that case, what you'd be doing the operation for is not just the weight loss, is to actually manage the diabetes. Then, as we move forward, and we're going to do quite a lot of these revisions, if you have somebody with a sleeve that has failed in the sense that they've got inadequate weight loss, or there's suboptimal resolution of obesity-related comorbidities, that person should be offered a SAID or a Roux-en-Y. And then in somebody who's got a failed sleeve and has got new onset gastroesophageal reflux disease, the Roux-en-Y is the procedure of choice. And as I've already said, in somebody who doesn't want an operation or is a high operative risk, really an endoscopic sleeve gastroplasty is the procedure of choice. You would also do that for somebody who prefers something that is non-permanent. So in conclusion, the Roux-en-Y gastric bypass has still got its place. It is the gold standard, and it's the gold standard for a reason. However, the one anastomosis gastric bypass is a legitimate alternative. It's a simple operation, much faster. It has got equal and in some series, much better weight loss than a Roux-en-Y. The SAID is a good option if you're talking about somebody who's super obese, or if you're converting from a failed sleeve. It results in better weight loss than the Roux-en-Y or one anastomosis gastric bypass. ESG has got its place. It fills a genuine special gap for patients who can't or won't have surgery. And of course, as the management is going to help us here, when we start doing quite a lot of these revisions of sleeves, especially ones that were done in international centers, the robot is really the way to go. So what can I say? When we think about the management of obesity, it really shouldn't be about, have we tried everything else? And yes, that has failed. Only then should we think about referring somebody for the operation. The question is, why are we delaying the most effective therapy? Especially if we look at all the different options that are available in terms of operative procedures. And then right at the end, I go back to the quotation that I started with, or the definition that I started with, and then to highlight the two words there, what we're dealing with here is a treatable disease. Sorry for the quality of the picture there, but this is the team at Dr. S, the multidisciplinary bariatric team at Dr. S.K. Matseke Memorial Hospital. This is Dr. Mate, who's my fellow surgeon. This is Moloko, our physiotherapist. Yvonne, our dietitian. This is Dr. Maduna, our physician. And this is Lunga, who's our psychologist. Sorry, I didn't put the picture there of Dr. Mantada, our anesthetist. And sorry. We're ready, we're willing, and we are accredited to help you and your patients deal with the problem of obesity. I think that's the end of my presentation. I will take any questions. Thank you for your audience.
Much, Dr. Mlimi, and for your very erudite and informative lecture today. I think it has informed most of us who never thought of bariatric surgery as treatment for obesity, but especially as one of the first-line treatment. As you said, it should not be only when this and that has failed. I think my take-home points that you mentioned are that obesity is in the country is growing faster than the rate of growth of the population. I think that's very worrying, that obesity keeps on increasing despite all the warnings that and the health education that has been given to our population. I think it's becoming it's becoming endemic, or if it is not there already. I think that's a big concern. But you've also said it affects almost every organ in the body, and actually it should be the treatment of obesity, management of obesity should be considered if it is present in any patient with any medical condition or even injury, as long as that person presents with a fractured ankle, a fracture or a neck of femur or any other condition, but also has obesity as well. The obesity should be treated simultaneously as well. Otherwise, you might not get there. It affects prognosis, negative effect on prognosis of any condition or even injury. I think that makes it a serious condition as well. But I think lastly, you also said it increases the cost of healthcare in the country. And I think for that reason, I think it's something that we should talk about again and again. And we hope that this is not the last time we approach the question of obesity in our webinars, but also we will tackle it also from all angles. All clinical disciplines will be affected. Thank you very much, Dr. Mlimi, for waking us up on this topic. It will always be a topical. It's always and I think people are trying, but depends what you try. I see in the audience today, we had, I think at the top of attendance, over 520 attendees. We had people of different disciplines, those that I know, of course, and I think they've heard all that what you've said. May I go straight to the questions that are in the chat box? But if any of you would like to ask a question to Dr. Mlimi orally, you may raise your electronic hand, and myself and the team that assisting me, led by Tolakele, will attend to your questions, and Dr. Mlimi will respond to them. Let's start with this one. I think this is from Dr. Nonhle Ngobo. She says, what's your take, Dr. Mlimi, or experience with pediatric obesity? Syndromes like Prader-Willi, budded beetle, can they be successfully managed with GLP agonists and or bariatric surgery? Any comment on that, Doc?
Sure, that's a very difficult one. Safe to say that, the area of pediatric endocrinology and pediatric metabolic bariatric surgery is a bit of a niche area. I don't have much expertise on that. I think in the country, there's probably one place where they can be sort of authoritative, and that is down in Stellenbosch. Yeah, so no, that one is not really my area of expertise. As I said, there are guidelines from the ASMBS and IFSO on the indications for metabolic bariatric surgery in the pediatric population. But, when we're managing this disease, we need to do it in a multidisciplinary team. And I think finding like a pediatric psychologist, finding a pediatric endocrinologist, those sorts of subspecialists is really the biggest challenge, or might be the biggest challenge. And as I said, it's a very specialized sort of niche area. I really haven't got much to say about that. So, no, I have not done or operated on a pediatric patient. However, I do accept that there is provision for that based on what the ASMBS and IFSO say in their guideline on pediatric and adolescent metabolic bariatric surgery.
Okay. Thank you very much, Dr. Mlimi. Let's take the hand of Dr. Mweketsi Mate. Dr. Mate, you can unmute yourself and put put your question or comment to Dr. Mlimi, please. You can go ahead.
Thank you very much. I hope you can hear me, Dr. Kinoshi.
We can hear you very
Loud and
clearly,
clear.
Dr. Martin.
Excellent. Thank you. I must say, 2026 is a great time to be a clinician treating obesity, because for the first time in forever, we've got so many options. Our patients have got an area of options in front of them, including bariatric surgery, which was very, very limited before. I just want to ask, Doc, I do agree with you. I think patients BMI 35, 40 plus they do well with their GLP-1s, but the weight loss, the weight regain is a reality. So I agree, more than 40 really ideally should get bariatric surgery. The challenge, of course, is the funders. Some of these medical aids don't even look at bariatric surgery. It's not even a consideration. And then, of course, those patients who self-fund. And I'm hoping you give us a comment on Turkey. which seems to be giving us a bit of a run for our money. And I suspect a lot of your revision may be Turkey-based.
Yeah.
So if you can talk to us about the path one must follow to get a patient to see you, eventually get the bariatric surgery.
Yeah, so we've opened up access in the sense that we've established centers like the one that we have at SK Matseke and some other hospitals, and the funding has not gotten up to it. So when it comes to that, I'll say a few things. So first of all, SAMs, who are sort of like the leaders in this conversation, are engaging with the funders on a constant basis. Right, so the EXCO at SAMS has meetings with the medical aides to sort of put to them the evidence that says what we're doing is not just cosmetic. What we're doing here, is life-changing surgery. And they seem to be winning. They're going slowly, slowly. The big problem is the quantum of the disease is so high that if all the funders decided to open all the options to all their members who are living with obesity, most of these schemes would collapse, right? So they are sort of holding out and not opening the access because they are afraid of that. As I said right at the beginning, somewhere between 30 to 40% of all South African women are either overweight or obese. If you translate that into 30 to 40% of female members of a scheme, then accessing treatment, whether it's a GLP-1 or an operation or endoscopic sleeve gastroplasty, that's going to put huge, huge strain on the funders. And I think, we can go this way and that way about it. But what most funders care about is not really what's best for the patient. I think, that's maybe a philosophical discussion for another day, but they're looking at the bottom line to say, if we open this option, if we open this GLP-1 and GIP story to all our members, and if we open metabolic bariatric surgery to all the people who qualify, we're going to collapse. So yes, there is that challenge when it comes to the funders, right? But that does not necessarily mean that we must now sort of throw our hands in the air and say, well, there's nothing we can do about it. You did mention the option of Turkey. I won't go into that now. Safe to say that people who believe that they can benefit from the operation and in whom us as clinicians recognize that they would benefit from the operation, they can be referred to any of the public facilities that do the procedures. So in Gauteng, there's two facilities that do the procedure. It's Dr. George Mukari Academic Hospital in the north of Pretoria and Steve Biko Academic Hospital in the Pretoria CBD. At Helen Joseph, there's some problems there. The program is struggling a little bit, but that's also another area where people are supposed to be able to access the procedure. So yes, there are the funders who have got their own problems, or there's some hurdle there when it comes to funded. Then there's public hospital, which has got its own problems when it comes to consumables and access and all of that. And then there is out of pocket, which then brings Turkey into the conversation. Now, if you listen to the patients who have had these procedures in Turkey, and by the way, what they do mostly there is a sleeve, which is why I'm saying as time goes by, we're going to do quite a lot of revisions because almost everybody who goes to Turkey gets a sleeve. And as I've already mentioned, somewhere between 20, 30% of the people need a reoperation within 15 years of that sleeve. The price, we just can't compete with that, right? I don't think we should even try because what patients will tell you, it's ridiculous, ridiculously cheap, but at what cost? So the patients go there, they don't know who operated on them, they don't know what procedure was done for them. They come back, they have terrible reflux from the sleeve, they don't know what to do about it. They end up going online, they end up coming to another surgeon who didn't operate on them to try and help them, deal with this problem. That's the one thing. And I think we also need to be realistic about, what's happening in Turkey, because SAMS has done some homework and they say that, look, realistically, this procedure is supposed to cost this much, right? Based on consumables, surgeon fee, anesthetist fee, etc., etc. And what patients are paying in Turkey is probably half or a third of what the procedure actually costs. So without trying, to throw mud on what's happening in Turkey, there must be some cutting of corners somewhere. There must be some things which are being compromised somewhere, right? So I think the way we should work around it is to maybe say, look, let's have a global fee, a certain fee that every private patient who comes in, we're going to charge them this much as a hospital. And I think our hospital manager at SK Mateke is working on that. He hasn't given us an exact number, but he's working on saying, look, if we are to balance the business and the social responsibility side of what we're doing as a hospital, we cannot charge what we would get from a funded procedure, but we can't go as low as what is being charged in Turkey. So we need to find some sort of middle ground somewhere. So really, that would be my answer about funding. But even then, even in the absence of out of pocket, even when the funder won't pay for the operation, there's still the option of getting a procedure like this in a public hospital. When it comes to the GLP-1s and the other obesity management medications, of course, that is really a pipe dream when you're talking about a public hospital.
Thank you very much, Doc. Maybe I hope you can see the questions and comments yourself on the chat group, but I'll read them out to you. We've got Professor Yasmin Adam. Professor Yasmin Adam is a seasoned obstetrician gynecologist. She says, great talk, Doc. I wanted to ask about pregnancy after bariatric surgery. Pregnancy is associated with reflux, slow intestinal motility. Is the side effect greater once a patient is pregnant? That is a side effect of bariatric surgery. Are there issues with absorption? Any comments from your side, Doc?
Yeah, thanks for that question. Yeah, so what we recommend is there must be an interval of minimum 18 months, ideally 24 months, an interval of 18 to 24 months between metabolic surgery and pregnancy. In other words, if there is a pregnancy and a delivery, there should be an interval of 18 months before we even talk about metabolic surgery, and the other way around. If there's an operation, then there should be an interval of around 18, 24 months before you start thinking about pregnancy. Lots of individuals who have had metabolic surgery do go on to have successful, uncomplicated pregnancies. Yes, the issue of nutritional deficiencies is a serious one, especially in the patients who have had some sort of a bypass procedure, like a Roux-en-Y or a mini gastric bypass, or something like a SADI. So yes, the issue of nutrition, sorry, is a very serious one. Therefore, the monitoring must be a little bit more intense in the individual who has had something like a bypass procedure. But insofar as the timing is concerned, insofar as the outcomes of the pregnancy, lots of individuals have, carried pregnancies to term without any issue after the surgery, just as long as you observe that interval and you monitor these nutritional issues, which you are aware they may become serious as the pregnancy progresses.
Great. Thanks, Doc. We've got Dr. Peter Malefetsani Ngatani, obstetrician. I think it might be known to you because he works with you.
I know him very well.
Dr. Ngatani.
Hey,
you can go ahead, please. You can go ahead, Doc.
Firstly,
Yes.
I would like to congratulate the doctor for the eloquency and the free-flowing information that he's giving to us. And secondly, I'm really impressed that he give accolades where it's needed to Professor Koto, who's we seldom forget our teachers and those who make us who we are. The third part is that I'm happy that the funders have recognized the fact that there used to be a struggle for them to recognize obesity as a disease. They used to take it as a cosmetic problem rather than a medical disease. So I am really impressed that there's made inroads on it. Now, the question is that with the funders not being easily accessible for this type of surgery and things, roughly what will be a round figure that, let's say, private patients wants to come and get herself or himself sorted out, because it can't always be her. There's always a him that also needs to be sorted out. What I know, if it's not easily available, I think I can talk to doctor when I meet him at the SK.
All right. Thank you very much, Dr. Ngatani. Actually, before you answered Dr. Mlimi, I think there's a similar question also from Dr. Itumele Mutlo, who says, how much is the ballpark cost of these procedures and what is the best way to fund them? Thanks for a comprehensive presentation. So I think the questions are similar. That's why I added that one as well, so that you can tackle both.
Thanks, Dr. Kinoshi. So about 3-4 weeks ago, I was with Dr. Tina Smith, who's actually on the EXCO, one of the EXCO members of SAMS. And he's into quite this data thing, collecting data, data-driven decision-making, et cetera, et cetera. And, he's gone through the numbers, through the different funders and different procedures as they are being performed in different places around the country. And what he's saying is, if we look at what the medical aid ends up paying for the procedure, this is now hospital admission, the surgeon, anesthetist, what are called ethicals, etc., etc. It's roughly around 160, 170,000 rand. That's what it actually costs the funder. Of course, you may go into some discussions about, the hospital groups then have a markup on what a supplier gave, but roughly there's somewhere 160, 170,000 rand. That is fair and reasonable, according to what the data says for a funded patient. Of course, we know that in our system, the numbers between a funded and a private patient are different, number one. And number two, 160,000 rand is actually out of range for a lot of people, which is now where I say maybe we should think about finding a middle ground, as providers, as practitioners, as facilities that offer these surgeries, to say, well, if it was a funded patient, this is how much we would bill, the funder. If this person decided to go get their procedure somewhere else, this is somewhere of what they would pay. Maybe we should be in the middle somewhere, right? And that's a discussion that our clinical manager or hospital manager at Dr. S.K. Matseke is having, with us, to say, can we not find something in the middle so that we can accommodate as many people as possible? If we're saying somewhere between 30 and 40% of all women in South Africa are living with this disease, and we want to make meaningful impact, right? And we agree that metabolic bariatric surgery is the most meaningful and impactful intervention, then we must really go out of our way, to try and accommodate as many people as possible. So to answer your question, yes, there is a ballpark figure that is based on funded patients, but I don't think we should necessarily use that as the benchmark. I personally am of the opinion that, we can find something a little bit more reasonable, as it were. But of course, we have to be in line with what we are, and that is business.
I think I've got one more question before I hand over to someone who's going to do a thank you to you and to the audience. A question from Nkosikhona, who says she heard you mention briefly biomechanics, and he says, how do the different surgical interventions affect biomechanics?
So the biomechanics speaks to the biomechanical effects of the obesity itself. So what does it do to the joints? What does it do to your hip, your knee, etc., etc. What does it do to your posture, your tendons, and the energy expenditure and all of that. So that's the context in which, the word or where biomechanics came in to say that when you are somebody who's living with obesity, there's alterations in these biomechanics, right? Then that results in increased strain in your joints, which then predisposes you to something like osteoarthritis of the hip or the knee, or it gives you chronic lower back pain, or it gives you chronic heel pain, that sort of thing. And so when you start managing the obesity, especially if you make a significant inroads into the weight, I mean, if somebody can lose about 40% of their total body weight loss from a SARDI, that does wonders for this biomechanics. So that is the context in which I used the biomechanics.
Thank you very much, Dr. Mlimi. I think we've reached the end of our presentation this evening. Thank you very much. But I've asked your mentor, your teacher, that you have already thanked so much for his contribution to your education. I've spoken to Professor Nkosikhona, who has greatly, generously and gracefully agreed to do the vote of thanks for us. Professor Nkosikhona, over to you, please.
Yeah, thank you very much, Dr. Kinoshi. And thanks to Dr. Mlimi for that very insightful and very comprehensive presentation. I think you really touched, on all the areas, around, obesity, the definition of obesity, the pathophysiology of obesity, and, and numerous very effective interventions that are available. The one innovation that you spoke about, robotic, its role in bariatric metabolic surgery, as you said, it's no longer experimental. There is now plenty of evidence that suggests that robotic surgery certainly gives a lot of advantages, particularly as you said in your presentation, the redo surgery. The operating times are shorter. There's less complications. I think it's really the way or the future of of how to do especially redo surgery. You also spoke about the second innovation, which is endoscopic sleeve gastroplasty. Now, this is really a no-incision revolution. And as you said, there is a particular cohort of patients that would certainly benefit enormously for endoscopic sleeve gastroplasty. And there has been a lot of writings, a lot of publications around this. It was approved by FDA in around 2023. It is really taken, the center stage for a particular cohort of patients. Again, as you said, the selection of these patients is absolutely key. The other innovation, is around, magnetic anastomosis procedure. Instead of the staples, now the magnet has really come now as a very effective way of doing an anastomosis without, the risk of staplers and so forth. These are the things really that are now unfolding. I think you touched about that, in your talk. The fourth one really is really the GLP agonist. Am I still audible? Can you still hear me?
You're
yes,
still very audible, Prof. Thank you.
Yeah, that's right.
Thank you.
I think the fourth intervention is really the revolution really of GLP receptor agonist in bariatric surgery. And really, they have really changed the landscape, of the management, strategies of patients with obesity. But I think as you indicated, again, a proper selection of patients is very important. That, one must be aware that, there is quite a lot of patients, that fall off, because of the quite considerable side effects. But that being said, it certainly is an intervention that is there, is available, and more of these drugs now are coming onto the market, as you have indicated. Again, it's something really that now we can utilize. We have a whole range of things in our toolbox in managing these patients. You spoke about intragastric balloons. Intragastric balloons, very important. I think you said, really the problem is that they give you temporary, the results are not, they don't last long, but then there's a subset of patients, for example, patients who have a special ceremony. We had a patient a young lady who was brought by a mother because wanted to attend matric dance and fit in a dress for matric dance. So that subset of patients, certainly intragastric balloon can be utilized. But again, there's been now evolution. There are newer, much more robust intragastric balloon. The one that has passed 3 adjustable balloon is also FDA approved. As you said, it can certainly be utilized a bit longer. So I think it's something again that must be considered in these patients. The other thing is really the evolution around selection of patients. The selection criteria, as you said, the ASMBS, the IFSO criteria have now been retweaked, in terms of selection of these patients. But then for patients, for example, with failed or weight regain, the role of GLP agonist in those patients. But that being said, I think the bariatric surgery, you demonstrated again the seminal paper, the Swedish obesity study, a very long-term follow-up that has shown sustained weight loss for patients that are offered bariatric surgery. Lastly, I want to talk about the safety of bariatric surgery. I think you alluded to that in your talk, that it is a safe procedure. It can be quite frightening, and many people, are very concerned about, the safety profile of this procedure. Certainly, it's now comparable to other procedures, arthroplasty, appendicectomy. And if you look at the mortality rates, 0.1 to about 0.4 for primary procedure. Even for redo procedures, you talk about 0.2, around 2% mortality rate. So by and large, these procedures certainly have become a safe procedure. So I want to thank you profoundly for a very insightful talk. I want to thank the audience that came. I want to thank the management of Clinix really for being visionary in putting together a bariatric center within SK Maseke. It's one of the best, certainly in the southern part of Gauteng, and really we're excited to see people like yourself certainly taking on this challenge, of providing lasting solution for this patient. But I also want to thank the host, Dr. Kinoshi, really for a masterful, moderation of this session. I want to thank, all the colleagues there that have asked questions, and everybody else, your team. We wish you the best of success, endeavors, as you take on this formidable challenge of assisting patients, with obesity. Thank you very much, Dr. Mlimi, and everybody.
Thank you very much, Professor, for your kind words, but also for your expertise and leadership as well in academia in general, but also in the healthcare sector, nationally and internationally. I think you are a great man. We thank you very much. I would like to thank you, Dr. Mlimi, a young surgeon upcoming, and for your time, but also for volunteering to do this presentation. And we invite all those in the audience and beyond who would like to do future presentations on any topic of your choice. I think we are welcome. You can just contact us on webinars@clinix.co.za. webinars@clinix.co.za. Or if you'd like any particular topic to be covered and we can look for a presenter for you, please let us know. You're always welcome. I would like to thank the team that's assisting me in the background. Tolakele, Sister Nesisa, Neo, thank you very much and good evening. We will meet again next week, Thursday, by the way, Thursday, same time, 18 hours. There will be another great talk for you. Thank you very much.